We have a 43 years old male patient presented with headache and otalgia.
Dahra, you hear the history?
نعم أستاذ. headache, 43 years old.
and
otalgia.
Okay.
ايه دكتور. الديفيوجن ولا اي دي سي؟ الحين السيكونس. time of flight. Mid contrast. Fast pushing.
دكتورة بالزحمة T1 و T2.
العادي و T2. دكتورة تدين شي بعد؟
multi sequence multi-planar MRI of the brain show abnormal signal intensity. It is hypo on T1 and hyper on T2, involving the right temporal and شوي بعد دكتورة right temporal lobe. It's cortically based. أي نعم. heterogeneous on T2. cortically based. الدكتورة restriction. أكو دكتور area of يعني restricted. بعد شوي دكتورة. أكو area of restriction. دكتورة بالفلير ممكن طلعي لي إياها؟ هايبر بالفلير consistent with edema يعني wear restriction and أفكر يعني ischemic cause. دكتور هي يعني sudden onset.
اي تقريبا دكتورة.
sudden onset.
نعم. يعني دا أفكر بإسكيميك كوز إنه إسكيميا.
where ischemia.
يعني هي ما تمشي ويا فد arterial territory. بالله دكتورة أكو
كونتراست تريدين دكتورة؟
إيه أريد الكونتراست.
اوكي هذا الكونتراست كلش حلو.
الترانسفيرس sinus on the left on the right side
بني.
not clearly visualized بالكونتراست. defect.
هذا الكونتراست دكتورة.
إيه هنا أكو filling defect right transverse sinus واضح هنا بالكونتراست.
بني.
نعم.
ايش بيه الرايت ترانسفيرسال؟
إيه يعني دا أحس بيه فد filling defect ممكن يمشي ويا thrombosis right transverse sinus
very
thrombosis.
very good. يعني constant filling defect تقريبا ايه.
نعم. ويعني surrounded by contrast وهو يعني filling defect واضح.
شو التربيله؟
دكتور عندك MRB؟
إيه دكتورة. هاكو السي بي انجل اذا تريدين تشوفين.
نعم. دكتورة يعني هي عندها فد risk factors hypercoagulability.
مو شيء يعني significant دكتور. عندنا هاي ماب ايمج موجود.
نعم.
بني. الصوت مالتك يقطع. أنا ما أدري بس عندي أو عند البواقين ما أعرف.
لا صوتها اكو قطع بي.
إيه ظاهر النت عندها ضعيف. زهراء تسمعينا؟
العفو أستاذ، هي بالدوام يعني عندها ماما فشوية النت هناك ضعيف.
يلا اوكي هي مشت خوش مشي. نشوف دكتورة شيماء علاء مكي.
تعال تسمع.
زهراء دا يتقطع الصوت مالتك، دا يتقطع النت يمش ضعيف الظاهر. شيماء علاء موجودة؟
نعم أستاذ، صباح الخير.
هلا صباح خوتي، مو بالدوام؟
لا دكتور، هم بالدوام.
أمينة؟
اي
تسمعي ايش
اي
سمعتي؟
دكتور، بدي أسمع.
زهراء صباح
شفت الاريا اوف اسكيميا بالرايت temporal lobe و there
نعم.
is a filling defect بالرايت transverse sinus. يعني the whole picture consistent with cerebral venous thrombosis with ischemia with infarction.
with venous infarction. excellent.
venous infarction.
هي قالت ميل 43 years، مو صحيح؟
اي نعم، بس الهيستوري دكتورة ما سمعت زين بلا زحمة.
كان هيدك
دكتور
والأوتالجيا.
بس
اوتالجيا.
تمام، بس بالتيتور تقدرين تمشينا الأكسيال. تمام. الفلاف دكتورة بلا زحمة. دكتور ما أعرف، يعني دا أشوف يمكن أكو الماستويد أوباسيفيكيشن بالرايت سايد.
بلي
يعني احتمال هي هذه الكوز، يعني
مال اوتالجيا.
ماستويدايتس. أي نعم، الكوز مال نعم دكتور.
اكسلنت. اذا البريديسبوزنج فاكتور هو
ماستويد
الانفكشن،
انفكشن.
نير باي انفكشن، وذر ماستويد او الميدل اير او هذه سوت شو اسمه. اكو اذر ريسك فاكتورز ممكن كوزنج غير هاي الكيس، يعني كوزنج
يعني دكتور هواي اكو
serious.
يعني هايبر كواجيلوباتي ستيز، او عندنا
Very good.
ديهايدريشن، سبسس، هواي اكو كوزز يعني.
فيري جود. بعد كونتراسبتيف تسوي
كونتراسبتيف يعني the most important بالفيميل.
فيري جود. شكرا دكتورة شيماء، عاشت ايدي. شكرا دكتورة زهراء. نرجع على دكتورة تبين احكي لنا على الكيس بنتي، واذا عندك توك حتى
ماشي.
تفضل.
اوكي استاذ. هاي ال MRI of 43-year-old male patient presented with sudden headache and otalgia on the right side. On the MRI, we see that there is an abnormal low T1 with slight high signal intensity on the T1, which is similar to the rim, and also heterogeneously high signal intensity on the T2 on the right parietal temporal region mainly, that show some blooming foci on the heme sequence, and also there is on the contrast study, it's obvious that you have a distended right sinus, especially the sigmoid sinus, and also on the in addition, of course, of the filling of the right mastoid air cells, and also enhancement of the mastoid air cell, also the external air has been involved. Also in this time of flight, we see an obvious filling defect here that's present on the right side, also is extended to the right internal jugular vein as well. At the end, I'd like to show you the restriction. Also, we have a focus of restriction on the right side. So the overall picture was diagnosed with the, this is the area of restriction. The overall picture was diagnosed with the right sigmoid and internal jugular vein sinus thrombosis, and and also acute automastoiditis as underlying cause, of course. And also there is some sort of meningeal thickening that's very obvious on the contrast study. Here you can see that there is also some sort of meningeal thickening on that side, and also even extending to the scalp region and also to the other external ear canal. So overall picture, as I said, it is a sinus thrombosis as a complication of acute mastoiditis with associated some sort of meningitis and cerebritis, and development of the some focus of the venous infarction with associated foci of hemorrhage, of course. Shall I go to the talk, Ustad?
اوكي تفضلي بدي انت
So our
تسلي
topic.
I think والله امشي هذا الكونتراست
Okay, so
شوية عليك هذا
I think it's partially empty. Yeah,
يلا
partially.
اوكي partially يلا.
Yes. The talk I chose to talk about dural venous sinus thrombosis for today. Okay. Today's talk is about the dural venous sinus thrombosis. We all know that dural venous sinus thrombosis is a subset of cerebral venous thrombosis and often coexists with the cortical and deep vein thrombosis, and present in a similar fashion that depend mainly on which sinus is involved. The epidemiology of dural venous sinus thrombosis is a rare condition, account for 0.5% of all cases of cerebrovascular diseases. There are several risk factors and a wide spectrum of the risk factor for development of the dural venous sinus thrombosis. Among them are hormonal, like exogenous hormonal use or pregnancy and puerperium, and also iatrogenic causes like steroid use or administration. Oral contraceptive pill is a very common cause of female patient less than 50 years, and also some sort of vaccine like COVID-19 vaccine was some sort of a risk factor. Prothrombotic hematological condition account for 35% of cases, including factor 2 mutation, sickle cell, and factor V Leiden. Other risk factors include skull abnormalities, among them trauma, compressing masses like extraaxial masses like meningioma, infection, especially the mastoid sinus, as we saw in our case for today, systemic illnesses, like any hypercoagulable status, dehydration in case of gastroenteritis, sepsis, malignancy, and some other connective tissue disorders. Overall, we have idiopathic causes, idiopathic reasons, or we have no causes account for 12% of cases. The main clinical presentation for dural venous sinus thrombosis is variable depending or ranging from asymptomatic to even coma and death. Typically, patients complain of headache, nausea, and vomiting. Neurological deficits are variable depending on which sinus are involved. The overall radiographic features is starting with the CT scan. On an enhanced CT, very first imaging investigation, since the symptoms are very general and non-specific. The finding can be very subtle when we don't have hemorrhage or infarction on an enhanced CT. On an enhanced CT, some sign may be present in case of dural sinus thrombosis. One of them is the cord sign, which is a type of the hyperdense vessel sign and refers to the cord-like hyperattenuation within a dural venous sinus on a non-contrast enhanced CT scan of the brain. This is due to the dural venous sinus thrombosis, of course. So this is an example of the cord sign on axial CT in non-enhanced of the brain, that we see the dense cord-like structure on the right transverse sinus because of the filling of that sinus with the hyper attenuated thrombus. The other CT finding or a sign on a non-enhanced scan is a dense vein sign. The dense vein sign is a type of the hyperdense vessel sign and refers to hyperattenuating thrombus within a cortical vein or a dural venous sinus due to acute venous thrombosis. When located in the superior sagittal sinus, particularly posteriorly, it sometimes refers to delta triangle or pseudo-delta sign. It actually is the same as the chord sign, but the difference is that we see the vessel in a cross section. But in the chord sign, we see it in all length, but in the dense vein sign, we see the vessel in a cross section, and it is called a pseudo-delta sign. This is an example of the CT scan, again, axial non-contrast study that we see a dense thrombus here and also in the superior sagittal sinus. It appears as a pseudo-delta or empty triangle or a triangle sign. This is called a dense vein sign. Another finding, we may see a vasogenic edema, which is secondary to venous hypertension. It could be unilateral, bilateral, cortical, peripheral venous hemorrhage. And also, you may see sometime a hemorrhage in the form of a cashew nut. So it is called a cashew nut sign, which is a radiographic sign described in a juxtacortical intracerebral hemorrhage due to cerebral venous thrombosis that typically appear again on the CT. This is an example of the cashew nut sign when we see an hemorrhage in a juxtacortical location of the right temporal lobe, similar to the cashew nut. With the uses of the contrast in a CT, it may use, or another term is CT venogram, it will appear as a filling defect in a sinus. So multiplanar reformatted CT venography has been reported to have about sensitivity of 95% for the diagnosis of dural venous sinus, which is a quite high sensitive. A sign on a contrast CT include empty delta sign, which is specific to superior sagittal sinus thrombosis, gyral enhancement or gyral enhancement, and prominent intramedullary vein, of course, because of increasing pressure on this sinus, so the intramedullary vein become very prominent. This is the example of empty delta sign on the contrast study on the CT scan when we see a filling defect inside the superior sagittal sinus. This is called an empty delta sign. The next investigation is MRI. MRI is able to both visualize the clot as well as the sequelae of the thrombosis or complications. A conventional spin echo sequences may demonstrate the dural sinuses, and also the clot will become acutely iso-intense on T1 and hypo on T2, mimicking a flow void on acute phase, with a subacute clot becoming hyper-intense on T1. With the most sensitive conventional MRI sequence for detection of the clot is susceptibility sequences such as SUI or gradient. On this, there are several staging for assessment of dural venous thrombosis severity on MRI. So it can result in paranemal edema and ischemia in its watershed area, the severity which can be graded as follow. When we have no imaging abnormality is grade 1, when number 2 is high T2, type 3 is high T2 with enhancement, and type 4 when we have hemorrhage or infarction is grade 4 severity. A contrast-enhanced 3D T1 weighted MRI is the most sensitive and specific MRI sequence in detection of dural venous sinus thrombosis, as we saw it in our case. And also MRV will demonstrate lack of flow in that sinus that's affected. This is an example of MRI appearance on the right transverse sinus that we see as similar to the flow void or filling defect inside that sinus, and also distended involved right transverse sinus. The major complication of the sinus thrombosis, dural arteriovenous fistula, which is an increase because of increased CSF pressure, has been reported as a possible complication after dural venous sinus thrombosis. As in these two images we see, this is a time of flight image that show a dilated middle meningeal artery, which is an arrow on both figures. This is A and this is B. Let's see this one. And also this is with widened transosseous vessel to the right occipital bone. Here on this figure, this is transosseous vessels. And flow void can be seen in the right transverse sinus and sigmoid sinus here, quite similar to our case today, but has been developed a complication and developed arteriovenous fistula as a result of the thrombosis. The differential diagnosis is, we have actually three main differential diagnoses. Number one, asymmetric anatomy. We know most of the cases we may have asymmetry in the transverse sinuses, particularly what's called a hypoplasia or atresia of the transverse sinus. The right transverse sinus usually is larger than the left in most of the patients, so it may give a pitfall about or give us a wrong impression that the sinus may be thrombosed. Number two is arachnoid granulation, usually characterized by well-defined filling defect within the dural venous sinuses, which is measuring 2 to 9 millimeters in diameter. The arachnoid granulation follows CSF signal intensity on all MRI sequence and should be on low attenuation on an enhanced CT compared with high attenuation of a thrombus that we talked about. And also finally, asymmetric flow in the transverse or sigmoid sinus sometimes can mimic a dural venous thrombosis. This is example of arachnoid granulation appeared on a CT, and then enhanced CT scan, bone window setting, and also on corresponding to MRI that's similar to the CSF signal on the MRI as well. And also asymmetric flow in a sigmoid sinus here mimic a possible dural venous sinus thrombosis on the left side that appeared on the arrow. This way may misinterpret as a sinus thrombosis. The treatment is in 50% of cases, cerebral venous thrombosis progress to infarction that usually presents some days later, unlike atrial infarction that may present immediately during the occlusion of the artery. The mainstay of treatment is start with heparin. Once the patient is stable, alternative anticoagulation is commenced, including direct oral anticoagulant or warfarin for at least 3 months. Sometimes interventional neuroradiologists can perform a catheter-directed thrombolysis by using a targeted thrombolytic in the affected sinus. The prognosis and the natural history of cerebral venous thrombosis is highly variable, with some patients having minimal or no symptom and uneventful recovery in about 65% of cases, whereas others have a fulminant course culminating in extensive venous infarction and dependency or even death in about 20% of cases. And this is our case that was presented for today. This is a contrast T1 that's obvious filling defect with a mastoid filling and infection. And this was obvious on the time of flight involving sigmoid and also internal jugular vein. And these are the references.
Please
Thank you very much.